As we are about to begin, we ask for continued cooperation this evening and wish you an enjoyable session. Please ensure that you are signed in with your full name, first and last name for record purposes. You can right-click on your name where there will be an option to make any necessary changes. UV students, kindly note that for documentation of your attendance, you are required to complete the feedback form, which will be sent later in the session. Lastly, we would like to inform you that this event is being recorded for storage and archives. Therefore, to ensure the integrity of our production, we kindly ask for your audio and video functions to be turned off. Thank you once again for joining us this afternoon and for your cooperation. It is now with great pleasure that I hand you over to our founding Executive Director, Anne-Marie Minghon.
Good evening, everyone, and a warm welcome to our specially invited guests and colleagues from the Mona and Cavell campuses. I am Anne-Marie Minghon, and I will be the chairperson of this evening's event. I would like to thank you for joining us for our 19th installment of CPALMSI on cytopathology. At this time, ladies and gentlemen, I am privileged to be introducing the speaker this evening, Dr. Harman Sekhon, who will be sharing his wealth of experience and passion for pathology in a brief overview of cytopathology. Dr. Sekhon obtained a Master of Science and Ph.D. in Pathology and post-doctoral fellowship at the University of British Columbia in Vancouver, Canada. He then joined Tulane University as a research scholar and holds a U.S. patent for novel in-utero gene therapy. Dr. Sekhon completed his residency training in anatomical and clinical pathology at the Oregon Health Sciences University and went on to do a Cytopathology Fellowship at the University of Washington, followed by a Surgical Pathology Fellowship at Oregon Health Sciences University. After working in the United States, he then joined Ottawa Hospital in 2008, served as a Director of Cytopathology, and promoted to full professor at the University of Ottawa. He is currently EORLA's Regional Director and Head of Anatomic Pathology at the University of Ottawa, Principal Investigator for Ottawa-site Ontario Tumour Bank, and Regional Cancer Pathology Lead for Cancer Care Ontario in Ottawa. Dr. Sekhon's main research interest is to explore the role of nicotinic acetylcholine receptors in cancer pathogenesis and modulation of these receptors for possible therapeutic targets. He has authored or co-authored over 200 original publications and abstracts in addition to the recipient of many research grants. He has served as the chair of Canadian Society of Cytopathology and is editorial board member of Canadian Journal of Pathology. He is also an active member of many provincial and national advisory boards and committees, including CCO, Thoracic Cancer Advisory Board, and Canadian Elimination of Cervical Cancer Implementation Group. An inspiration to many, we are honored, pleased, and privileged for him to be here with us this evening. And so, ladies and gentlemen, I ask where you are to welcome the very knowledgeable and most certainly the very passionate Dr. Harman Sekhon. Hi, Dr. Sekhon, you are muted. I think you may want to unmute.
Yes, thank you very much for a wonderful introduction. I'll just move on to with the lecture. I really enjoyed this. I would also like to thank Dr. Alfredo Walker. He is our esteemed colleague, and he's a wonderful person. I really enjoy working with him, and his abilities and capabilities and management skills is wonderful. And it's always a pleasure to just participate in some of these medical school teaching. So just to start with the cytology.
Sorry to interrupt. Are you able to show your put on your video, please, if possible?
So to start with, cytopathology is a branch of pathology. So which is actually, whenever we just talk about pathology, there are various other areas of it. Then anatomic pathology is part of it. And then cytopathology is a branch, and most of the places have it as a division of pathology. So the diagnosis using the cellular features, that is the main part of it, compared to that we have a biopsy or a resection specimen where we just look at the intact tissue, but here we look at the individual cell details to just make a diagnosis. So initially it started in 1928 when George Pepniclaw, he was just doing a research on mice, and he was looking at astrocycle of the mice, and then he found that they can see some changes in the cells that comes with the Easter cycle. So as these mice were cycling. So then in 1930s, he just came up with that you can actually see the cells which are shed from the cervical canal, and then you can just look at them and then can tell from the way that they present that what area they are from, if they have any changes in them. Either it could be due to infections, or it could be due to the dysplastic changes. So currently this is a tool which is used not only for screening but also to diagnose a wide range of the benign and malignant entities, and the scope of it has been really now quite wide compared to what it was designed to be. So it just bifurcates, or it has a kind of two areas. One is the gynecological pathology, cytology. Other one is called non-gynecological cytology, even though it just covers a wider area, but that is how the terminology has been just stuck with. So cytopathology, when we look at, there is a sample collection and sample preparation. Those are the very fundamental things that are needed in order to just have a proper examination of these cells. So the sample collection could be two types. One is exfoliative, the other one is interventional. The exfoliative by itself also has the kind of a two ways. One is which is spontaneous, that happens in effusions or in sputum, whereas the mechanical is where it is kind of irritated or just taken out. That is, for examples are the pap smears that we do, or the bronchoalveolar lavages, the brushes, the washings, anywhere those kind of things are done. On the other side, the interventional is a fine needle aspirate, where they just go in, target the lesion, and then aspirate some of the cells, and then those are smeared and then looked at. And so the sample preparation taking from samples is also done. At that time, when it just was slowly evolving, it was called conventional smears. Now those, because they were just spread on a slide, and then you can just look those slides under the microscope. But in 1980s and 1990s, the new way of just looking at those samples evolved, and that was a liquid-based cytology. And the two more common companies that which actually participate in is one is SurePath, the other is ThinPrep, which they have mastered, and then they actually have monopolized that part of the cytology preparation part. So what are we looking at is mostly because it was designed to be both the cervical and the vaginal cytology. At that time in 1928, when it showed that you can actually see the malignant cells in the vaginal smears, but it was not really until 1940 that a Canadian physician, actually Ernest just introduced that you can actually take the vaginal spatula instead of using a pipette to collect the cells which are shed from the cervical canal by a pipette and then smear them. But you should actually reach into the canal and take the sample from there and smear that. So why it is being done? Because it turned out to be, it was an excellent screening tool. So because it used to be at that time, the number of cases that people used to die of cervical cancer was actually #1, but it just currently ranks around number 10 in the cervical due to the cervical cancer screening. But on the world stage, means that is actually what is in the US and in North America, but on world stage, there are about 500,000 cases are that, and almost half of those, in fact, die of it. So it is second to the breast cancer. But the reason is because less than about 5% of the women get the Pap test done in developing countries, means where the population is relatively high, proportionally higher compared to the developing countries. So in the US and also in North America, as well as in the Europe, there are two types of the screening programs. One is organized, the other one is opportunistic. So the organized is that you just target the specific age group, that is from the age of 20 up to about age of 65 or 70, whereas the other ones are the which they just present for something else. And then we just take those patients and then screen them. So here is actually a cartoon to just show you, miss, how this thing is done. As you can see on your left-hand side, miss, you just have a wooden spatula, because that is at the front part of the cervical canal. You just scrape the cells from it, and you smear it on the slide, and then that slide is actually, then you stain it. So what it looks like this, miss. On the right hand side, you can see it is the smearing, because this is quite uneven one, and then the areas which are quite thick has lots of blood or the other fluids. On the other hand side, miss, is relatively thinner. So it is to just get a very good sample. It is always very cumbersome, but that is the easiest way and the cheapest way of doing it. When we look at under the microscope, that is what we look. Means you really have to sift through the cells of interest, that which ones are the ones that will display the different type of findings compared to the normal cells. On the other hand side, there's a liquid-based cytology that, as I mentioned, there's a sure path, and then there's thin path. These are the preservatives. They come in the vials, and then also then there is a brush that comes with it, that you take it, go into the cervical canal, even endocervical canal part of it. That is what you just do. You put it in a vial, and that is sent to the hospital. At the hospital, they use the machine that prepares these small ones, instead having a bigger that as I showed in the past, that big the smears, and you have a small little button-like structure where these are evenly spread. And as you can see, that is what the difference is. On the left-hand side, the slide shows that the one before from the smear. On the right-hand side, individual cell details. And it makes it much more easier to detect the changes that may happen due to the dysplasia changes or due to the reactive changes. And so that helps to increase the accuracy of interpretation. So in order to understand that how it actually works, we have to look at the cervix. In the cervix, what you see is that there is a endocervical canal, and then there's an external surface of the cervix, and there are two types of epithelium. The outer one, which is more rigid, it is squamous epithelium. The endocervical canal is lined by the glandular epithelium. So at that time, at that place, there were both of these glandular epithelium and the squamous epithelium that meet. It is called scomocolumnar junction. So that junction at the early age is inside the cervix. But during the reproductive years, it just comes outside the surface, outside. And then after the menopause, it again just reverts back into the inside of the cervical canal. So what it does is, because it comes outside during the reproductive years, and at that time, means this is the area which is the most vulnerable to undergo metaplastic changes and the dysplastic changes, and ultimately just have a cancerous changes. So this is what it looks like. Miss, I showed you before, that was the normal cervix, what it looks like with the scomocolumnar junction. But when there is a dysplastic change, you see this whitish structure, and then if around it there is a ring, and that shows that this is much more different than the one that is inside, which is much more reddish in color. So this whitish structure is a dysplastic change, and that is what we see if you just take sections from it you just follow it up. The normal will look like that there are basal cells at the bottom, and then it's finally matures towards in a very orderly fashion. In the low-grade dysplasia, only the basal part, the 1/3, the lower part of the thickness of that squamous epithelium is much more busy, and it has the cells which are slightly different. But as you look upwards, it still matures, but there are some cells which looks different than the others. In case of the high-grade dysplasia, the same kind of features actually become full thickness. And full thickness, that it loses the polarity, the normal just maturation process, and it looks much more different. And in cancer, obviously, that is the most, change happens, and it starts to invade into the stroma that is underneath. But how do we actually look at that? How can cytology tell us that these changes have occurred? Because here we are not really seeing the polarity, we are not really seeing the maturation, we are not really seeing the invasion. But there are certain features that we just focus on. And what we focus on is here to just give you the slight little pathogenesis for this thing, because all this part is actually related mostly to the HPV infection. So HPV by itself there are about more than 120 subtypes of HPV. Out of those, about 40 of those are actually infect the female genital tract. Out of those, about 15 are high-risk subtypes. And from those, the 13 we actually usually look at, or we just try to just, immunophenotype, or just to do the DNA analysis. And then from those, 2 HPV 16 and 18 actually composed of about 80% of the cases. So 16 and 18 are the high risk and the highly prevalent type of HPV infection that is present and is related to squamous cell carcinoma or adenocarcinoma of the cervix. So how does it happen? It just, the HPV, that's a virus, just comes in. It just have a episomal integration into the cell, but as it moves it moves up, and then it eventually just gets, it packaged and then in a capsid, and it is kind of, it just, goes out of it. But there are some other cells which it will start to multiply, and because of the multiplication, you have many more cells that are actually involved in the process. And then in that way, because you get to see that there is actually high-grade dysplastic changes because of the application process. So what happens is that in the low grade or in the early on, with some of the cases, there's an infection, but it clears as it just moves upwards, and it sheds. And if the patient is not really consistently exposed to the virus, then that patient may just get rid of the infection. But sometimes it just integrates into the DNA, it multiplies, and then it leads to the full thickness of dysplastic changes. So it will just become persistent. And then the persistent, sometimes that too, it becomes precancerous, but it can regress. But in other ways, it just progresses to squamous cell carcinoma. There are risk factors, means the age at the first sexual intercourse, number of sexual partners, condom use, and sexually transmitted other diseases. There are many confounding factors that can actually participate or affect the process of this infection. So when we look at the cytology, we have to know what exactly is the normal structures that we should be seeing. Then only we can just look at the abnormal structures. In the normal structures, as I said, there is a squamous epithelium, there is a glandular epithelium or columnar epithelium, and then there is a transformation zone or the squamous-columnar junction. So that is what it looks like. Means if you look at these cells, the superficial cells, they have a small nucleus in the middle and ample cytoplasm. Then there are intermediate cells which have less cytoplasm and the cell nuclei slightly bigger. And then you have the parabasal, which is just above the basal layer. So that's where you get actually a lot more, but these nuclei are very round and very even, kind of a very regular nuclear contours of it. And then there are basal cells, which are smaller in size, and they have really high nuclear to cytoplasmic ratio. But again, the nuclear features are the one that we just, focus on, and then that gives us much more information. So then we just moved on to the low-grade dysplasia. So low-grade dysplasia, as you can see, means here is a biopsy that shows that at the bottom part, there's a slightly busy, but again, means on top, means it looks like it is maturing, but the cells have these vacuole-like structures or halos around those nuclear features. And same thing actually, in fact, we see when we just look at the cytology specimen. Here is on the left-hand side are the normal cells, which are the superficial or the intermediate cells. And intermediate cell is the one that actually we just look at as a target, and then we compare everything else to it. And on the right-hand side, you can see the cell is almost 3 times the size of the nuclei of the intermediate cell, and there's a clear halo around it. And that is because of the presence of the HPV. And then so similarly, you can also see the binucleation, similar kind of a halo. And so these are the features. Not all the cells that you will have on a smear or on a liquid base that will have this, but the representative cells, and depends where you actually, how and where you have done the smearing. Because these lesions are not really present all over the place, they can be focal. So that is, it all depends, the proportion of the cells that you get on your smear or in a liquid base will be the number of cells that you will see on your slide. Then there's a high grade where it's just, as you can see in the biopsy, there's a kind of a full thickness of it, means you don't really see those coilocytes or the halos, but what you see is a lot of mitotic figures as here and there. Those mitotic figures often are at the basal part normally, but as the high grade dysplasia, you see them right going to the surface. When you look at this, at the cells, means here is an index cell, that are intermediate cells, but on the right hand side you can see the cells which in fact are very hyperchromatic, means they are really dark, and then their chromatin is really clumpy, and then also the nuclear contours are not really round compared to the intermediate cell, but there is a lot more the cell size is smaller, and there's a high nuclear to cytoplasmic ratio. So when we see in the low grade, means the nuclear cytoplasmic ratio is not significant increase, but in case of the high grade, that increase is very easily detectable. And then you can, from there, looking at these features, you can tell that it actually has a high grade dysplasia. Again, going back to the same thing, because these are focal changes in the cervix, so that's why you will see only few cells, or sometimes a group of cells that will be present, and then you can just make your diagnosis of high grade dysplasia. Relatively in North America, means you don't really see the cases that actually have progressed to the squamous cell carcinoma. But when I was doing my fellowship in Seattle, there was one doctor, and she was very involved in some of the African countries, and then she used to bring some of those pap smears from there. And that's how we actually looked at how to understand what the invasive cancer looks like. So if you look at a biopsy, this is what it looks like. It looks like that there is a invasion into the underlying stroma. But when you look at the cells also, they look very different. They, instead of just kind of a pink or eosinophilic, they look orangeophilic, and that there's some of them are very small and are very minute in a way. The cell size doesn't matter, but there's a cellular pleomorphism. It means that the nuclei are variable sizes. Some of the cells, which I can see here, means that is called the tadpole cells, which looks like a tadpole. Then there are the fiber cells, which looks like really long ones. They just come from the invasive cells, because that is how the invasion happens in in cancer, or in particular in squamous cell carcinoma. So these are kind of the features you see them. In addition to this, because there's also, it causes, because there's a multiplication of these cells, it also causes the tumor diaphysis or the necrosis of the tumor. And that is what you see in the background. When you see all these features, you can be sure that it is an invasive malignancy, and you can flat out just call it that it is an invasive carcinoma. Certainly there is a history that there is a mass rather than a plaque-like structure. So that also helps you to make the diagnosis. So these things are quite easy to identify, and then you make these diagnoses. And when that diagnosis is done, it often is followed up by a biopsy, which is much more invasive. So compared to this, it's an easy and quick screening tool, and one that happens, you just confirm it with the biopsy. So that is how the cervical cytology screening and diagnosis happens, and it saves lives, because it is relatively outpatient kind of a collection. And then so although the things are now changing in North America, we are actually moving on to the HPV testing triage, and then you just take the cytology sample compared to currently what the guidelines are, that we do the cytology, and in odd cases that where we cannot really figure out whether it's a true dysplastic lesion, we call it ascus. In those cases that the HPV testing is done. Okay, so that is the part of the cervical screening. And then currently there is also a lot more. You might have heard that means that there's a vaccine that is being given, that is that has different subtypes, and then there are bivalent or trivalent or quadrivalent, means different types of it. And then also just moving on to the area of the HPV testing, which is much more sensitive than the cytology. And so that is the way to move on to the elimination of cancer. In Canada, we are expecting to eliminate cancer, cervical cancer, by 2035. So that is the target. And so already the things are being implemented in that regard. So let's move on to the non-gynecological cytology. Means it is a wide area. It is a totally different compared to the cervical screen, cervical cytology. So here we are just actually looking more so about the diagnosis rather than just the screening, using it as a screening tool. So what is this? This is actually less invasive compared to you will do a biopsy. It is cost effective, it is specific, and it is accurate as you will get the information from a biopsy. So instead of just having an invasive and a lot more and longer to just have a diagnosis, it is a quick. So there are all different type of things. In the lungs, you can have bronchial brush, bronchial wash, bronchial wash, then there is a kind of endobronchial ultrasound guided FNAs or the transthoracic FNAs. We'll talk about it in a minute. Pancreatic, you can do the aspirates through the stomach or through the duodenum with the ultrasound guided again final aspirate. Common bile brushings can do it. Liver FNAs, gastric esophageal brushing and FNAs. Lymph nodes, so you can just look for the metastasis of the other tumors, or you can look at the primary tumors such as lymphomas. Thyroid salivary FNAs, so kidney, cystoscopic urine, those are kind of done the washing. Cerebrospinal fluids, effusions, cystic, and also bone metastasis. So there's a variety of ways. Actually, you just look at these kind of samples and you can make a diagnosis. And then it is relatively quicker because some of the areas we do have, it's called ROSE rapid on-site evaluation, which is very helpful. And it is kind of, as that one will say, as a bedside tool. to just, make a diagnosis. So what we have is in the cytopathology, and again, it is a similar kind of a preparation. It's either these are the conventional smears or these are the liquid-based cytology on the right-hand side. It's similarly, you see the same kind of a preparation that you see for the, cervical cytology. What we do is that, as I mentioned, that we do here in Ottawa, we have the rapid on-site evaluation that any of the operators, it could be a radiologist, could be respirologist, or it could be ultrasound person, they will just go in and then aspirate the cells and give it to the cytotechs or the pathologist. They will make the smear right there, look at it under the scope and tell them that this is what it is, whether it's a benign or it's a malignant, or if it needs further workup, that is brought back, and then more ancillary studies are done. So as I said, non-gynae cytology, it is a sensitivity and specificity. Again, it depends where you are getting the fluid, if it's a fluid or it's a washing or it's infections, or it could be benign versus the malignant, because if it is benign ones, entities have a relatively lower sensitivity compared to the malignant ones. And then also the site of the lesion also depends whether it's superficial and deep, because sometimes there's not really easily accessible, even though sometimes they use 9-inch needle to just go into the lung lesions and try to just get a good tissue. So often in these ones there are very few cells that you're looking for. We have done the diagnosis just looking at 10 or 15 cells, and you can, if you have all the features of a process, you can actually give the diagnosis that is what it is. So in that regard, it's very few cells that you can utilize, but at the same time, you can also do wonderful other things, which are the future of pathology, and that is about the molecular testing. So it's a primary versus a metastasis. And again, I have just touched on the part of the rapid on-site evaluation. We call it ROSE. So here I will give you some of the examples, how the things are done, and so that you can understand what I really mean by it. So here is a case. There's a 55-year-old woman with a lump in the right neck. And then it showed that 1.3 centimeters lesion, and also had multiple other nodules in her neck. And the repeated ultrasound showed that in 1 year, this thing actually increased to 2.2 centimeters. So they used the ultrasound, and then they just used the needle. That is what you use, the same needle, just the size of the about 25 gauge. And you aspirate the cells, and give it to cytopathologist or cytotechnologist, and they smear at that on the patient side. So this is what actually it showed. It showed that the smear one is on top. That was the first few of the passes, we call them, that when you do the aspiration and give it. So it was very hypocellular, as you can see, but there were these clumps of stuff. So these clumps are, in fact, is colloid that is found in thyroid. And these few cells are, on the other hand side, are the follicular cells. If you're looking at them, you can tell the person, the operator, is in the organ, so that the person is aspirating things from the thyroid, because there are follicular cells present, and there are this colloid present. When these things, the ratio of the colloid to this follicular cells, we can tell that it is actually a benign process. So it shows these features are compatible with nodular goiter. But on the other hand side, that the few aspirate, passes afterwards, we found that actually there were some cells which look much more different than the follicular cells. These are bigger, and then also they were hyperchromatic again, but they also have these like little circles inside the cells. We call them intranuclear pseudo-inclusions. So these intranuclear pseudo-inclusions are typical or pathognomonic for papillary thyroid carcinoma. So whenever we see those, and whenever sometimes you can see the small little papillae, but not very often, that these are the features which are typical of a typical, one particular entity. And so because at that time, you even looking at few cells, when you see these changes, you can just call that it is actually a malignant process. Because the thyroid by itself is very vascular, so it bleeds a lot. So you cannot really do a biopsy. So it is, it is kind of a universal that only the final aspirates are done. Here's an example of another case which is a 60-year-old gentleman with the smoking history, has a swelling in the front of the ear, and in a couple of years it has been increasing in size. And when they did the examination, it shows an ill-defined mass, and the final aspirate, as you can see, was performed. So what it showed was the sheets of oncocytes. As you can see that these are like flat sheets. These sheets have small kind of round nuclei in the middle, and there's ample cytoplasm around it. And then so all of these cells actually look the same. What is also important is to look at in this case is because the background looks a little bit necrotic. And then also it looks, we call it kind of a, mechanical oil kind of structure in the back. Not a lot of, as one will see in a malignant tumor necrosis, but it's slightly different. And then in this case, here is a comparable when it was resected to show you that there is a neoplasm, which looks like, there are these oncocytic cells outside. There's a lot of lymphocytes. And then the same thing, there are small little things. Some areas did actually show on that slide as well, the lymphocytes. So when we see those information, and just compare with the clinical history, then you can just tell, because it's an ill-defined mass, it was slowly growing, and it is doughy, like kind of little, you can push it down because of the necrotic, that machinery, all kind of stuff inside it. And so these are the features of a Werthin's tumor. So this is a benign tumor, so you can rest assured that to the clinician or the surgeon, that they can even wait if they have to just to resect it out, or they can just resect it out anytime, because it is not a malignant process. So these are some of the examples that you can actually look at. Here's an example to show you about the urine cytology. And then that is when you just look at that. There is a 88-year, just an example, 88-year mound with the hematuria, and a cystoscopy was performed. So when they look at, this is what actually looks like in the bladder. There are some spots which looks a little bit hemorrhagic or hyperemic. And then so when they just go and then flush it out and then wash it out, that is what you see. When we see that there are cells which in fact have, again, very eccentrically looking nucleus, which is again very coarse, and the chromatin is very coarse, and then there's a high nuclear to cytoplasmic ratio compared to normal urothelial cells, which again are kind of a, have a lot more cytoplasm around it, and then nuclei are small. So it's a all comparison, as well as the morphological features that you look at to just come to a diagnosis. So this was a high-grade urothelial cell carcinoma in that patient, even though this was a very patchy process. So those are the examples. Let me give you the examples of the respiratory tract. This is actually the most common thing that actually most of the cases we do get from the respiratory tract. The reason is because it just interacts with the airflow and then all that kind of stuff. And then also there are the malignant lesions. So there are different type of things. In fact, Mr. Sputum was one of the early ones, non-gynecological cytology specimens that people used to just determine that if there was any abnormality in those cells. So spontaneous deep cough one can do, and then because that can bring up the kind of cells or the debris that is present inside the bronchi or in the proximal airways. And then so that you can look at for the infection, or you can also look at the malignancy. So they're induced sputum, and then there's a spontaneous or the morning sputum, that are different types they use. But this practice is now kind of very less. We rarely receive these kind of samples. What we receive most commonly are the bronchial brushings. and for the malignancy or the bronchial washings. The brushing and the washings are essentially at the same time, because once they just do the brushing, then they just do the washing of the same area. So it's just both kind of samples complement each other. Then there is a bronchoalveolar lavage where they just instill about 30 to 120 mils of saline into the lungs, and then they aspirate out, because that actually brings some of the things that are maybe present at the peripheral part of it, because in the bronchial washing and then the brushing, those are only done in the proximal airways. So what it can bring about the alveolar proteinosis or the impaction of the mucus, infections, bacteria, fungal, and then other kind of problems. I'll show you some of those examples. And the other type of samples that we receive are the final aspirates. So those can be transbronchial or transtracheal. Those can be transesophageal. Those could be transthoracic or percutaneous. So those are the kind of aspirates that we receive either from the respirologist, or we just receive from the radiologist. Again, in order to just determine what exactly is, you have to know what is actually the normal structures present in those cells. So this is a section of a bronchus. As you can see, the ciliated epithelial cells on the top, and then underneath is the stroma. And when we just, when they just scrape the washings, do the bronchial washings and bronchial brushing, that is what, you most of the time you will see these normal cells, and that these cells are kind of scattered. As you can see, the single cells with the cilia on top, or they can be in group of cells. But in order to just identify some of the features, which I will tell you, we have to know that how actually sometimes the same cells can just display in a different order or different configurations, and then one can actually, get misguided, or can just, misdiagnose some of these things. So therefore, you need a very good knowledge about the normal structures that are present. Here's a kind of a section of the lung from the periphery. These are the alveolar structures and the terminal bronchioles. That is what actually looks like when you do the bronchoalveolar lavage, and some of you will be doing it. And then you should know, Miss, what exactly are expected from those areas. So there in the periphery, there are these smokers macrophages, or the alveolar macrophages. So they can be they are often the predominant part, but those are needed in bronchoalveolar lavage, so that we know that actually the sample is adequate or not. So here is an example of a case that is 68-year-old male with a saddle nose and has a non-enhancing slow-growing lesion. He also has a microhematuria, and a bronchoalveolar lavage was done. So what we found was, in this case, that there were cells, those same macrophages that I showed you. Sometimes they can have lots of smokers dust inside those things, but they also had this little golden brown chunky material that was present inside them. And that the patient, this is hemosiderin laden macrophages, and the patient actually was ANCA positive. ANCA positive means that the person has vasculitis, so he was bleeding in his lungs. So that is why this macrophages was laden with the hemosiderin. So sometimes, because you can also just kind of misinterpret it for the area of for smokers, those dust for the hemosiderin, you can actually do the Persian blue strain. And then here you can see on the right, means all this is just iron positive. So it confirms the diagnosis that it actually is just a remote hemorrhage in the lung. So the person had all these opacities in the lung was actually due to the focal hemorrhages here and there in the lung. So here's another case from the 55-year-old woman who has shortness of breath, has bilateral consolidations. The blood culture was negative, and then bronchial alveolar lavage was done. What we see on the right-hand side is just the clumps of cells, which actually had the bilobed nuclei and then also had a kind of eosinophilic cytoplasm. In addition, there were these little charcoal-laden, we call them charcoal-laden crystals. And so these are the telltale or the features of eosinophilic pneumonia. So you don't really need to just do the biopsy in these cases often, because these are benign things. You don't really go in and do an invasive procedure. So these are the things that can be easily, taken out, and they can be examined and a diagnosis can be made. Some of the things, it looks like a worm, but it actually is Crushman's spiral, we call it. The people who suffer from the asthma, they will show up these spiral, because this is essentially its mucus that is inspissated and it forms a kind of a cast inside the bronchi. There are other areas where the people work in different occupational areas where they can get exposed to different type of metals or different type of dust. In this case, this patient was exposed to asbestos, and these are called the asbestos bodies, where it is drumstick-like things, and this has been stained for the iron, because the asbestos has iron contents in it, as well as when the macrophages try to phagocytose these asbestos fibers, they also just protein is deposited, as well as the cell membranes of the macrophages are deposited there, and then those things also turn to be positive for iron. And so that is how we just diagnose what exactly is the tumor burden, asbestos burden in these patients who have been exposed to asbestos. And then in that case, they can just also have compensation. The other things that you can sometimes see that the patient has, bilateral or unilateral or focal kind of, consolidations in the lung. And then those areas are, again, bronchoalveolar lavages are done. So these are the examples that people, often it happens in older people, or those people who do not have very good reflexes. And then in those cases, they aspirate. And then so here it shows some of the plant fibers that are present inside. And then so you can diagnose that, in fact, it is an aspiration, not really a malignant process. So the patient is saved from surgery. The other example is 43-year-old female with the history of CML, and then also has a bone marrow transplant. And then she was unwell, and then they had a non-productive cough. When they just did the bronchial lavage, it shows kind of this mush-like structure, which has a kind of a negative images in it. You can see there is something, but you cannot really tell, because these things are just a part of a little ball-like structure. So, but when you just take it and then you just sustain with the special stains, you can see that here shows like small little collapsed hat-like structure. So this is a Pneumocystis cerevisiae, and then so that is the infection, and then they can be easily treated. Although these patients also have the micro specimen done, and then to see the similar kind of things, but not all the times. So here's another example, the patient with the AML and also has a bone marrow transplant, but again, here the bronchoalveolar lavage was done. As you can see here, the bronchus that is very, very hyperemic. And when we look at there are some cells which shows the multinucleation and the margination. So these are the features of herpes. So easily you can just detect these changes, and then you can tell your clinician that this is what we found, and then they can just give a much more targeted treatment instead of the empirical treatment. Another case is that a 67-year-old gentleman who came to the ER with the shortness of breath, and then he had a CT scan, showed a mass in the right upper lobe, and was also sent for culture. It turned out to be that this patient, in fact, had this fungal hyphae, which were septated and were on the 45-degree branching. So easily you can just, with a very least invasive process, you can make a diagnosis that this is, in fact, is aspergillus infection. So aspergillus can actually make aspergillomas, and it looks like tumors. And sometimes these have to be resected because you cannot really treat them properly, but these can be invasive or non-invasive type. And invasive type, which is a more disseminated kind of infection, you have to treat with the antifungal agents. Okay, so that is the kind of, of what we see in these cases. Here's another example of the 72-year-old woman who has a giant cell arthritis as well. He's on different kind of medications. She immigrated from Cambodia and was treated. It showed that she also had bilateral opacities on her X-ray. And when we just looked at the bronchial lavage, we were kind of surprised to see. First, we thought that probably these were the cotton fibers were there in the lavage by kind of a contamination. But then I found out actually they all look much more similar. So it turned out to be that it was the patient was suffering from strongyloides sarcoidosis, and which is quite common in Asia and Africa and in Central and South America. So these are the things which is kind of that can save someone's life, and then easily identifiable, and then for very non-invasive process. So now let's quickly and just move on to the part that I just wanted to take care of, we don't have a lot of time, about the lung cancer, which is the practice for the cytopathologist is much more common, and then also it is very useful to get the diagnosis with the least invasive way of it. There are squamous cell carcinoma, small cell carcinoma, adenocarcinomas, and the carcinoids. So some of these are like squamous cell carcinoma is more central, adenocarcinoma is more peripheral, and the mesothelioma that is present on the surface of the lungs. So if one can actually look at the CT, means there are different type of the fair ground glass opacity. Some of the students will be just going and become a radiologist, and they will look at these things, part solid or the solid type of lesions. And so they actually have the morphological features of the tumor that is most is specific or more so for an adenocarcinoma kind of features. And they can do the imaging, and they can do the fluoroscopy, CT, ultrasound, and the CT guided fluoroscopy, and then they can do the final aspirates using these techniques. As you can see that there are different type of needles which are used to do these do the FNAs, means some of the fenestrator or some are straight needles. And then also we do the staging of the lung cancers using the same kind of techniques. It's an ultrasound, which is a very small kind of probe that is done inside, sent inside the trachea, and then the paratracheal lymph nodes or the mediastinal lymph nodes are assessed whether they're metastasis or any of the primary type of lesions such as lymphoma. So we have an algorithm here in Ottawa, means it is that how we actually use, and then different ways of it. And all these algorithms actually help us to just come to a definitive diagnosis. So here you an example to just give you that 67-year-old male came with the chronic cough, and no significant change in appetite, means that but there was a weight loss. So here is on the CT, it shows a kind of spiculated lesion, which is much more central though. So what it was actually that they also did sent the sputum from this patient. What it looks like, these are, we call it, fish in a stream, that the cells, because that the way they smear, and then the cells, when you look at higher kind of a magnification, you see some of these cells are orangeophilic, other ones are kind of a blue in color, and then they make the syncytial groups of these cells. And these cells are actually similar to what I showed in the cervix. So this is a squamous cell carcinoma, which have again the dyskeratotic cells and then these very weird looking cells. And so these can be easily just identified on a fine needle aspirate. And when you look at the histology, that it just confirms that it is squamous cell carcinoma. It forms a squamous pearl. And then when you look at grossly, that is what actually it looks like. Means it's just more centrally located in the, because its origin is from the central airways. In case, because some things can be difficult to diagnose, whether to give an accurate diagnosis, we use the ancillary studies. In this case, we did the ancillary studies for the P10, P40, as well as CK5. So these both are the markers for the squamous cell carcinoma. So that way you can make a specific diagnosis. The reason for that is because there are different type of chemotherapeutic agents for different type of cancers. So you have to, we have to just give a specific diagnosis so that they can be treated appropriately. The other is an adenocarcinoma, which is quite common. It has a squamous cell carcinoma used to be the predominant part because of the smoking relationship. But now adenocarcinoma, because smoking is relatively less common. And then in this case, what we hear is almost 40% of the cases that we see are adenocarcinomas. However, it can also be related to the people who smoke more commonly. And there are slightly different kind of features. Here is just to give you that what they look like. They are relatively varied. The necrosis is relatively less common compared to the squamous cell carcinomas. And when you freshly slice them, that is what actually they look like. On the other hand side, when we do the final aspirate, instead of just looking at those discaryotoid or orangiophilic cells, we see the cells which are actually blue in color, and they have the very prominent nucleoli. Large nuclei, very prominent nucleoli, and then also we can see that they forming a little bit columnar shape in cells, and so that we can tell that these are actually adenocarcinoma.
Sí. Sí.
Hello? Okay, so if we are in doubt that in order to just, because sometimes these things can show up in sheets, and we can do the, again, ancillary studies. Here is the case. Here is an example of, to show you the TTF1 and surfactant, which is positive in adenocarcinoma and is negative in squamous cell carcinomas. These are some of the algorithms that we actually use. There's the percentages, and then we just kind of try to just tease through these ancillary studies or the tests that we do in order to make a specific diagnosis, as I said, because some of the cases, for example, the adenocarcinomas, there are much more targeted therapies, which are the molecular targets that we can identify. We can do the next gen sequencing in those, identify those, and then there's, instead of having a standard chemotherapy, which is intravenous, one can give just oral 1 pill a day, and that has a much better prognosis compared to the standard chemotherapies. So this is a very high level, kind of a diagnosis that we have to do, and then now we do the molecular testing as well in order to just, direct the patient to the more appropriate therapies. Give you another example here, my 68-year-old male, which has a 55-year-old history, and then also has a dyspnea, rapid weight loss. And it was shown that that person has a centrally placed kind of a tumor, which was targeted. What it shows was very hyperchromatic cells, very little cytoplasm, very coarse chromatin. And when it was, this is the cell block on the right-hand side. When we just look at this, looks like, very difficult to identify, but this is an example of the small cell carcinoma. Small cell carcinoma, because that also gets, and we need a very, specific diagnosis, because the management is totally different. And also it has a, patient has a very bad prognosis. Within 1 year, most of the 80% of the people die of it. And if that is treated quickly, means there's a quick response, because they are highly proliferative lesions, and then so that in case to target those means it's relatively easier, although the long-term prognosis still is dismal. So those were the kind of tumors that we do, means that is the kind of stuff that you can do the FNAs, and then so you can reach at a specific diagnosis and can just tell the clinicians and that how to manage those patients. But then there are other areas that is kind of a fusions where also there's a lot of fluid that is present. It could be present in the pleural cavity, it could be present in the abdomen, and then sometimes it's liters and liters of it is aspirated, and then so that aspirate is sent to us. And then we just try to look at that, whether it is a benign process due to some obstruction and the person is accumulating a lot of fluid, or it is just, in fact, is due to the malignant process that is, again, is a kind of a, instead of transudate, it is an exudate, and so that can be just identified and then treated accordingly. So in same way that I just showed you before, we have to know that what is normal. So here is just to tell you the example, what is normal is, because these are the mesothelial cells. They can be single nuclei, or they can be binucleated, and they have a little fuzzy stuff around them. The fuzziness comes because these have microvilli around them. So because when you just have the two cells together, there's, because of the microvilli in between them, we call them windows, and then these windows are the kind of a very sign that this is a mesothelial cell rather than any other epithelial cells or something else coming from somewhere. So these things are very important for us to keep it in mind, because that is how the things are diagnosed. And here's an example. Most of the time is there are very few cells which are actually come outside. Person may be having an infection. There is very few mesothelial cells shed into the pleural fluid or in acidic fluid, ascites. But when there is a primary malignancy, then there's those cells because proliferate, and there's a lot more cells which are shed into those areas. And here's an example to show you that this is actually is a mesothelioma, because the person that is a primary malignancy of the mesothelial cells or the serous membrane that is just covers these, all the organs in the abdomen as well as the lungs. So that is how we just identify those things. But in that same area, in the effusions, can be just from metastasis. Here's an example to tell you that this is a squamous cell carcinoma, similar to these features that we look for, that we call it, nuclear molding, and then small cells which are just stuck together. We don't really see the windows that we see for the two mesothelial cells stuck together. And then only in a few cells, you can actually, looking at the features, you can identify and diagnose that this is a metastasis if the person has a history or a mass somewhere and other place in the lungs. This is an example that the patient can be from anywhere else. Is the most common thing that actually we see are the breast cancer that they metastasize to the pleura, and then through the lymphatics, it just comes in there and then just homes in that area and just starts to proliferate, because there is a lot more fluid present which just works as a cell culture. And then so these cells, just free floating cells, they start to proliferate and then just adhere somewhere on the pleural surface as well. So these are the ways, and we do the immunohistochemical stains to identify actually where is the primary. And sometimes that is the first diagnosis we tell that actually this person probably has a primary either in the lungs or the thyroid and the abdomen or anywhere else. And then so similar kind of things we do in cerebrospinal fluid. So these things are, cytology has evolved over time, and now it is just in the field of molecular testing, and then just even looking at few cells, and then so those are very helpful to manage the patients. So these were the references, some of the things I was taken from there. So that is all for today's lecture. Miss, I would be happy to answer any of the questions that you may have.
Good night again. So for anyone who would like to ask Dr. Sekhon any questions, they can do so now. They can either put it in the chat or they can speak. Okay, just to get the ball rolling, we had some questions that came in before. Dr. Sekhon, could you speak a little bit about the pathway in which you took in becoming, or the pathway in which a person would take to become a cytopathologist?
Yes, actually, I was when I was doing my residency at that time. I was supposed, before doing residency, when I did my master's and PhD, I was mostly just interested in the pulmonary pathology, and then that is actually now too. That is, cytopathology and pulmonary pathology are my two primary subspecialties. So at that time, because the reason that I actually became the cytopathologist, because I trained in the US, and then because cytology is one area where you actually have a patient interaction, and you are able to just give the diagnosis on the patient side. You do the final aspirates, and unlike here in Canada, it is slightly different process. Means mostly the other clinicians and the radiologists, they do it. But in States, means most of the lumps and bumps that you can see, it is the cytopathologist who does that. And then at the same time, the diagnosis is given, and the transition from the diagnosis to the treatment is very quick in States. So as soon as you just get the diagnosis, the patient is actually moved to the next phase, and then they are just seen by the oncologist. If it is a higher stage disease, if it's a lower stage disease, they will just triage to the surgeon. So that is the area which I really enjoyed. The other part which I really enjoyed was because when you know the cellular details, it is much more easier to look at the whole tissue section to make a diagnosis, because cell are the independent things where the changes happen, and the rest of the arrangement is slightly helpful, but at the same time it is very, very rewarding for me, and I really enjoyed it, that part.
Oh, nice. So the next question we have is, what would be your advice to persons going into or thinking about doing cytopathology?
Cytopathology, I think it is, if you're really interested in it, means it is a science within science by itself, because of the details that you look at. And then also there are, as we are just progressing, these things, as I said before, that for the gynae cytology, means that the emphasis is getting less, but this is increasing in the non-gynae, because people these days, as you might have heard and then looked into, that they want to have the least invasive surgeries, least invasive procedures, and it's a quick turnaround time, so that people don't really have to stay in the hospitals for a long time to just get those things done. And so this is a quickest way of doing it. And then also because of the the molecular testing, which are done on a very small amount. Sometimes you need only 10 cells in order to just determine what kind of a target is present, and then with the least invasive procedure, if you can just make a diagnosis and give that, so that is a very rewarding. And then so you take pride in it, that because you are helping the patient just to quick diagnosis and quick recovery, and then also just at the end, may say it's a better kind of a lifestyle or just a patient care. So I think those who are just thinking about it, it not only will be just helpful for you to just have a career in cytopathology, but also even if you want to just go in other subspecialties, and those are also good. I would also say that, I don't know, Mr. how is at your place, but people should have a rotation in pathology in order to understand how the processes happen, and then what takes time and why it takes time. So in order to know that what are the importance and what actually the reports mean, and what they can really explore more to just treat or manage their patients.
Thank you so very much for the advice. We would like to call on anyone else who would like to ask any questions at this time. Okay, so now we would like to share with you some comments in which we have gotten from the audiences while you were doing the presentation.
Okay. Well, thank you very much, Miss. If you're loving it, you're gonna be, you're gonna enjoy it, Miss. I think these are the small, simple steps that you take to become a good doctor, and then the more you learn, and then more you accumulate, and the more you just apply that knowledge to get where you want to be. No, I really appreciate it. Thank you very much.
Thank you so much again, Dr. Sekhon. We truly appreciate your informative session. As Deepak Chopra once said, gratitude opens the door to the power, the wisdom, the creativity of the universe. You open the door through gratitude. Firstly, I would like to thank you again, Dr. Harman Sekhon, who, despite your busy schedule, you graced us this evening with an amazing and enlightening presentation where we all were extremely grateful to learn about cytopathology. We'd also like to extend our gratitude to Dr. Alfredo Walker, one of our founding executive directors, for joining us this evening. We appreciate your endless support and thank you for playing a key role in supporting us throughout our journey thus far. We thank you all for taking your valuable time, effort, and consideration in the investments to nurture and properly establish the future of pathology. It is not only an act of success, but one of greatness, showing us the paths that you have all walked. I would also like to recognize Justice Katyan Lachu, High Court Judge of Trinidad and Tobago, who joined us earlier this evening. Last but not least, ladies and gentlemen, I would like to thank you all for accompanying us tonight and making our event a success, and we look forward to your continued support. To all our UA students and staff across the 3 campuses, the University of Ottawa and Eastern Ontario Regional Laboratory Association, and especially to our specially invited guests, thank you, thank you. Ladies and gentlemen, this marks the end of our session this evening. Thank you all for joining us on 19th installment of CPALMSI. And our next session will take place on the 10th of November and will feature Dr. Rhonda Hudson from the UA Mona campus, who will be giving us an overview of clinical forensic medicine. We hope to see you at our future events, and good evening all.
Good evening.
Before we go, I would just like to extend my heartfelt gratitude to Dr. Sekhon. Dr. Sekhon has been a source of support in all my academic endeavors since I landed in Ottawa 12 years ago. We started out on the Pathology and Laboratory Medicine Grand Rounds, which eventually morphed into an annual conference. And now with him being in the position of divisional chief, I'm very, very grateful for all this support. So thank you very much, Harman. Dr. Sekhon is actually on holiday in Vancouver, but still found the time to do this. So, that must be recognized. The Pathology Club of the University of the West Indies, under the stewardship of its founding president, Ms. Anne-Marie Ming Hon, as well as the current president and the current executive, is well positioned to provide medical students with opportunities that I did not have 25 years ago, 30 years ago, when I was embarking on entering into pathology as a postgraduate area of interest. So kudos to you all. This relationship, professional relationship between the University of the West Indies and the University of Ottawa has the potential for doing great things, producing great things for, that's mutually beneficial. And I hope Ms. Ming Hon and President Ramsaran and the others on the executive do not waste the opportunity to seek out opportunities with Dr. Sekhon to pursue electives here in Ottawa. So on that note, I just want to say good evening to everyone, and see you next month as well. Thanks.
Thank you very much, Dr. Walker.
Thank
It's
you.
wonderful to see you that you're there. I can see Trinidad and Tobago in the background.